Welcome to AETCM, the Emergency Medicine Channel. A 34-year-old female professional diver was brought to our ED from Lakshadweep with complaints of pain over the right ankle and occipital region swelling after diving.
Occipital region swelling?
On occipital region swelling was there. And on right ankle, one swelling was there, which she mentioned she developed after diving. So from there, they had referred her here. On initial 10-second assessment, patient's airway was patent, patient was speaking in full sentences, breathing-wise, respiratory rate of 18 per minute with a saturation of 99% room air. Circulation-wise, heart rate of 78 per minute.
Any breathing difficulty was there?
No, she didn't complain of any breathing difficulty. BP 120/80, capillary refill time less than 2 seconds. Disability-wise, GCS was E4, V5, M6. Pupils equally reactive, and exposure-wise, she was afebrile. Coming to sample history, at this time we had not taken any adjuncts to any primary to
there is nothing
survey.
to take as adjunct.
So we came to sample history. Patient had a history of deep sea diving 34 hours before she presented to the ED. She had dived to a depth of 31.6 meters and gives a history of being in that depth for around 15 to 20 minutes. She mentioned that she had followed all specific protocols while ascending. The time of dive was around 8 to 10 a.m. the previous day. Duration of the whole dive was 45 minutes, and time left when she reached the surface was around 11 to 12 minutes still. Around 13 hours later of the dive, she observed the first symptom, which was a swelling of around 2 into 3 centimeters above the right ankle, on the right leg, which was tender on touch, and another swelling on the back of her head on the left lower side in the occipital region. It was tender to touch and no discoloration and no other symptoms as such. There was no complaints of any breathing difficulty, any chest pain. So initially she went to INS Sanjeevani the next day. Symptoms occurred in around night 11 p.m. Next day 7:45 a.m. she went, which is after 24 hours of the dive. There she was started on 100% oxygen, and then chest X-ray and ECG was done, which were within normal limits. And then she was evacuated and referred to Kochi. She reached here at 9 p.m., which is around 34 hours after the dive. From here, patient was emergency. Like we shifted the patient for HBOT, like hyperbaric oxygen therapy.
On arrival to ER, did the patient have any clinical findings?
She just had the swelling. Same
occipital lobe as well as the left ankle,
yes,
right?
This side, left side, and right leg.
Right leg or ankle?
Just above the ankle on the medial side.
Okay. On palpation, how was the swellings?
On palpation, it was firm, tender on touch, but no discoloration, nothing. The pain is not on, like pain is continuous. It's not like really.
Yeah, that's understandable. But it is firm on touch.
Firm on touch.
Firm on touch. Okay. Fine. Only in that area, angle area, and on the occipital region. Fine. So, what is your diagnosis as such?
So, provisional diagnosed as type 1 decompression sickness, only having muscle, like joint, any single joint or any muscle pain involvement, like pain or any single joint involvement.
Okay, you are saying it's a decompression sickness.
Yes.
DCS, right?
DCS.
Decompression sickness. Okay, type 1 DCS, fine. Okay, so what is decompression injuries or decompression illnesses? What are the complications that we are talking over here?
So, decompression sickness basically will encompass decompression sickness as well as arterial gas embolism.
Okay.
Other than complications of diving.
Why these things happen?
That is because of basically due to any when we dive like deep sea, inert gas molecules will be dissolved in our blood,
because
especially
of
nitrogen.
Something that we do?
Because of physics, like the laws.
We are normally breathing in oxygen.
Oxygen, yes.
Isn't it?
Yes.
Our blood contains
70%.
oxygen transport through hemoglobin. So oxygen is dissolved in your plasma. We have a mixture of nitrogen and oxygen in our lungs. This is normal us. Now this person is going either under the water or above a certain altitude. Both these things can happen. Decompression sickness is not only in diving, it can be fast descent from a altitude. So altitude is much more rare because at least 18,000 feet you have to go up. Decompression sickness due to ascent is one what we see. So even if you don't have to know the laws and all, the basic thing is when you go deep, your pressure inserted over your body is significantly elevated. Okay, so this person has got what
31 meters.
So 31 meters. So each 10 meter atmosphere pressure increases by 1. So 33 it is around 4. Atmosphere pressure
3 plus 1.
Yeah, 3 plus 1. So 4 atmospheric pressure is exerted, and that will cause the air bubbles to come out from their dissolved form. This is the issue. Now, when they are diving deep, most of them really don't have much of a problem. What are the does diving cause any problem, or only ascending causes problem?
Descent also causes problems.
Descent also causes. What is the problems with the descending that will be usually seen?
Descent will cause trauma, especially trauma to middle ear. So basically we will have barotrauma of aortic barotrauma. Then otherwise we can have sinus barotrauma, or we can have inner ear barotrauma. Usually it is because pressure inside the middle ear, when we go, the pressure, all air containing cavities will, because of the pressure outside, it will shrink.
Yes.
So the middle ear gets pulled inwards. Middle ear, tympanic membrane. Tympanic membrane, not middle ear.
So basically everything is getting pulled inwards. So any cavity which already had air now will experience less volume of air. The volume of air is not changing per se, but since the pressure is increased, volume will decrease. And since volume decrease, that area will feel like it is collapsing on itself. So usually people will have middle ear fullness because the tympanic membrane is now pulled inwards. So they will have severe pain. Some patients will have hearing loss. But this is usually what will you do when you have a fullness of ear? You will try to blow out your through your nose, holding your nose, you will try to blow to open your ears. That's it. But only one major complication is there. That is significant decrease your inner ear circulation will have trauma. There can be rupture. Only that part you need to know. How will those patients present?
They will have sensory neural hearing loss.
So you won't be able to check sensory neural hearing loss on ED, no? What is the other finding?
Pain.
Inner ear.
Imbalance. Vertigo.
Patients will have vertigo. So this patient, one of the most important thing is patient is descending. And the descent, rapid descent is the one that causes the pressure difference, and the pressure difference causes inner ear labyrinth to be having a small and oval window rupture. But the thing is, since labyrinth fluid is getting lost, patient will have vertigo and patient can have tinnitus. These are the two findings. So patient will present to you with a history that immediately on descent I develop these symptoms. So this is not decompression, because decompression is when you are ascending. This is descending. And so why this is important is that decompression symptoms can also affect ear, isn't it? Patient can also have vertigo, patient can also have hearing deficit. So you need to know whether it's a decompression illness or was it a descent injury. So this is how descent injury patient will say, as soon as I started descending, I developed these symptoms. And the other one, patient will say, I descended, I was normal, I was immersed for water for some time, and during coming up or later only I developed. That part we will get to know. So these are descent injuries. Then you have ascending injuries, which we call as decompression illnesses. Now, decompression illnesses contain decompression sickness and
arterial gas embolism.
Arterial gas embolism. So basically, as you told, when we are ascending up very rapidly, the pressure is
Increasing.
reduced.
Ascending up.
When you are descending, pressure,
Outside pressure increases.
atmospheric pressure
increases.
increases. Because atmospheric pressure increases, air volume decreases.
Yes.
Air is more dissolved in your blood, dissolved in your muscles, ligaments, tissues, blood. More air is dissolved. But the moment you start ascending up, the dissolved air starts bubbling out and it starts coming out. So you need to stop at particular stops for some time so that the whatever air that is escaping will come out through the venous circulation to your lung and your lung can expire out. But if you are rapidly ascending, there is lot of air. The earlier the much air that is dissolved now want to escape. And since pressure is coming down, the volume of air increases. So there is lot of bubbling comes. Now this bubbling is the one that causes all the problems. Now how the bubbling can cause problem? As she told, two things. Either decompression sickness, which is anything that doesn't cause arterial air embolism and arterial embolism. So any patient who get arterial occlusion symptoms is AGE, arterial gas embolism, and anything other than arterial gas embolism comes in decompression sickness, isn't it? So what are decompression sicknesses that you know?
So decompression sicknesses are type 1,
and type 2.
So type 1 is involvement of single muscle or single joint.
Single joint, no, single muscle.
Single joint, basically shoulder, especially shoulder, knee, elbow joints and hip joints.
Distal joints usually and usually larger joints.
Then type 2 is...
So that patient will present as? Pain. Persistent pain. Patient will say, whatever I do, pain is there, but
it not exaggerates on movement. Does
correct.
Not increase.
That is the important thing. You can do passive and active movements. Patient will say there is no worsening of pain, but pain is relentless. It is always there.
Then type 2 decompression sickness will basically have pulmonary symptoms. Patient basically will cough,
one more, you told muscles. So how will that present as?
Extremities and the left. Lymphatic obstruction. Swelling.
Swelling. That is
swelling.
how this
yes,
patient presented. Localized swellings will be there, which will be mildly tender to touch, and it won't move away. Why that is important? Okay, we will come there. But usual muscle, if trapped air is inside the muscles, there will be localized swelling without any anatomical coherence. It will be like encompassing. Okay. What else?
Then
so this is joint and muscle. What else?
Then type 2.
Type 2. What is type 2?
Type 2 will be pulmonary involvement will be there. Patient will have cough, breathing difficulty, chest pain, hemoptysis. All these histories will be there. Patient can develop pneumomediastinum, pneumothorax. Like with such presentations, patient can present to ED. Other than that, patient can have neurological symptoms. Neurological symptoms, patient might feel truncal constriction and with ascending paralysis. With autonomic dysfunction can be there. Sexual dysfunctions can be there. Then patient might have vestibular syncope, like vestibular staggers. So patient might have vertigo, hearing loss, tinnitus. And present, all this will come under type 2.
Okay, so in type 2, we are looking at 3 major organs. Most commonest one is pulmonary. So as we told, there is lot of bubbling of increased volume of gas, isn't it? This all gas is going where? It's all gas trying to go to lungs. So when all this increased volume of gas is coming to your lung, that can cause barotrauma. And that barotrauma can cause rupture of alveoli, irritation to the lung and the airway, that causes cough, non-productive cough. It's usually non-productive, and if it is productive, it is usually with mild hemoptysis. Now what else it can cause? It can cause, barotrauma can cause surface rupture causing pneumothorax or pneumomediastinum. So pneumomediastinum, pneumothorax, cough with hemoptysis, we are looking at a lung injury. But certain patients may not have that. Certain patients may have Neurological deficits. There are what type of neurological deficit?
Ascending paralysis patient will
There can be two type of neurological deficit. See, when we are saying neurological deficit, there are two types. One is due to type 2, direct type 2 injury causing spinal cord like lesion injury, and it can be arterial gas embolization to severe. But since we are saying AG as separate entity, we will not say it now. But it can be severe like features or spinal cord lesion like features. Type 2 is when you have spinal cord lesion like features. Usual features will be, as you told, ascending paralysis. Basically, it will be like a transverse myelitis. Or so patient will have sensory deficits, patient will have loss of balance, reduced sensation, and progressive ascending paralysis can happen. Usually it will not cross over to the cervical region, so it's very unlikely patient develop breathing difficulty or phrenic nerve palsy and all, but patient will have weakness. And the problem with how will you say whether this is a spinal cord injury or whether this is a decompression injury? For example, a patient presents to you with a bilateral ascending symmetrical paralysis with sensory loss, very acute onset. What is your primary diagnosis? You are looking at an inflammatory condition of the demyelination of the spinal cord. Transverse myelitis is your primary suspicion, right? How will the transverse myelitis also will have urinary retention, will have constipation, overflow, incontinence. Patient can, as you told, sexual dysfunction. That means difficulty for erection. These things is there in transverse myelitis too. So what is the differentiating feature? There is no spinal level. In transverse myelitis, you have a spinal level, you have a sensory level, you have a motor level, you have an autonomic nerve level. In gas embolism, in decompression sickness, almost many areas of spinal cord is affected, so you will not have a clear-cut level. But symptoms are nearly similar to transverse myelitis. That is why, as you told, girdle-like constriction feeling. Basically, it's a bed-like squeezing sensation, but it's not in one spinal level, it is over many levels. Isn't it? That's why it is called as girdle-like. What is girdle? Girdle is that piece of clothing, right? So it's over a huge area. It's not single spinal level. The other one we say bed-like compression, band-like compression, right? So it's a single spinal level. So spinal levels will not be there. But as we told, other thing. What is the third thing? Third thing is cochlea. The inner ear, cochlea. So this is why initially we told you can have vertigo and tinnitus in descent also, because during decompression also you can have. How will the patient present? Patient will present with hearing loss, fullness of ear, with vertigo, but usually it improves over time. So, but as we told, onset of symptoms will be on ascending or after ascending. The other one will be during descent. This is a complication feature. So, type 1 over, type 2 over. Now you have type 3 or arterial gas embolism. Some people say it is type 3 DCS. Some criteria put it as a separate entity. But anyhow, arterial gas embolism. What is that?
It is any neurological deficit just after ascent. Like means after decompression.
Your type 2 will also come in that.
No, it has to be any CVA like features. Like patient have to have deficit as such. Like any stroke, any seizure will come under type 3.
Basically, it's very simple. Arterial gas occlusion. Any arterial ischemic features come in arterial gas occlusion. So basically, now you have a air bubble which has shunted over from the venous circulation to the arterial circulation. As we initially told, when bubbling of gas occurs, all the bubbling of gas occurs usually in low pressure systems, that is venous system, or it is transported through vein to the lungs to expire out, isn't it? That's why we told there can be barotrauma, alveolar injury, pneumothorax, pneumomediastinum, all these things, right? But if at all air bubble, not air bubble, much air bubbles pass through the venous system to the arterial system, either through the capillaries. Since it is air, it can pass capillaries. We say pulmonary embolism cannot pass from venous system to arterial system because thrombus cannot pass through capillaries, but air can, because it's single-celled capillary. Air is much more lighter, so air can pass through capillaries to the pulmonary vein coming to left side, going to arterial system, causing any arterial occlusion. It can be cerebral, it can be acral, it can be other organs. Got it? But any arterial occlusion is arterial gas embolism. Isn't it? Or else, what is other this thing? Patent?
Foramen ovale.
Foramen ovale. So, patent foramen ovale can also cause
this right to left shunt.
Yeah, right to left shunt. So, once you suspect that, that is why post ascending, if patient is having hemiplegia, hemiparesis, or acute organ ischemia, you should suspect acute gas embolism. Got it. So, these are the conditions, findings and presentations, right? Okay. So, in ER, how will you approach this patient? What are the major things you need to ask as a ER physician?
So on arrival, initially ABC, like airway breathing circulation.
Let's think that airway breathing circulation is normal, like this patient.
Okay. Then one of the things is air entry bilateral equal, because suspecting pneumothorax, so we have to rule out.
First history, this patient, everything is normal. You told amble history, right? So in amble history, what are the important things you need to ask?
So we have to ask whether the depth, like to what depth she had gone.
Good.
The time of depth, like duration of the whole dive. Then whether she had stopped at every stop or not. Whether she followed protocols or not.
So basically, first question is, are you an experienced driver or not?
Yes.
Experienced divers usually know the protocol and they stick to it, rather than a recreational person, isn't it? More risk with a recreational person rather than an experienced diver, but anyone can develop this. Then, as you told, depth, duration that is spent at that depth,
then the gas which they used.
Good, very good. So usually what is the commonest gas that is used?
Nitric.
Normal air. Normal air is the one, but high pressurized inside the cellular, but it's normal air. But what other mixtures can happen? They can take nitrous, that is enriched oxygen, more oxygen with nitric content, or helium with oxygen, or helium with nitrogen and oxygen. But doesn't matter. The only thing is, whatever gases they have taken, according to the pressure, the effects will differ. That is the only difference. But that is why we say inert gases. Nitrogen and helium is inert gases. But symptomatology will not change whatever gases they have taken. Okay? Okay. But what is the other important question you need to ask? Whether the person has done only a single dive or not. Because as we told, the physics is basically when you dive, more gases get dissolved, and when you ascend, the gases that got dissolved comes out. But if a person has ascended and developed some symptoms, for example, it's an experienced diver, and on ascending, the diver starts getting symptoms, some symptoms like a breathing difficulty or a pain or something, they may identify it as decompression symptom, and they can dive down again. They can go for another dive so that the gas that is bubbling out will again get dissolved. This is recompression. Okay, recompression is what we do in hyperbaric oxygen therapy. Okay, but that is in a controlled situation. When they re-dive, the oxygen that was, not oxygen, sorry, gases that was bubbling up get dissolved, and the amount of dissolved gases will only increase. So the next time when they ascend, actually the volume of gases will increase. So multiple dives cause much higher risk for decompressive illness rather than a single dive. So you need to ask how many times you dived. What is other important question? Were you symptomatic as soon as you emerged or developed later? Because as soon as emerging, if the patient is symptomatic, there was a significant gas presence in the system. Usually those kind of patients will have type 2 type of DCS, that is neurological deficits, or more commonly pulmonological complications. So, but a person who develops over time usually develops type 1 symptoms, which is bubbling of gas trapped in ligaments, muscles, joints, and all. Fine. Okay. Now, those are to the diver, about the dive. Is there any other conditions that can worsen a patient's presentation over time? Like you told, this patient was completely fine when she emerged, right? She was completely fine. Then she came to Kochi, and in Kochi she developed the symptoms and she went to INS Sanjeevani, right? That is very easily 12 hours later
she
the
developed 12 hours later.
dive, right? Minimum 12 hours later. So why after 12 hours she developed? She was completely fine when she emerged. When she emerged, there was no decompressive illness. 12 hours was done. So why after that she developed?
Because micro nuclei can be there. Like,
That is
can
another
obstruct it.
history we need to ask. Where did she die?
Lakshadweep.
Lakshadweep.
Fresh water.
No.
Seawater.
As we told, when you go under the sea, atmospheric pressure increases. When you go above the sea level, atmospheric pressure decreases. So this patient has dived, emerged in Lakshadweep. She was fine because she is at atmospheric pressure. So whatever gases, bubbles that was forming out, her lungs was okay in expiring it out and taking care of it. But then she traveled through air. And when she traveled through air, commercial jets travel at 30,000 feet. So her atmospheric pressure is low. Even then, normally aircrafts have pressurized cabin, but this patient is highly prone to develop symptoms after the air travel. So one of the advices that is given to divers is to avoid air travel for 24 hours. So most probably after this travel she developed the symptoms because the air travel must have exacerbated her normalized she has followed every protocol, done everything, and she is asymptomatic. But the air travel must have worsened the symptoms. Luckily, she didn't have any significant thing. So that is one history we need to ask. Were you traveling on road or did you have air travel as such? Another one is alcohol ingestion prior to diving, and other comorbidities, obesity, elderly age, all these things are important. Okay, now what are the red flag signs that you need to look in emergency?
Airway, because of the mechanism of dive, patient can have some C-spine injury. Can have
that is trauma. We are not dealing with trauma.
Breathing difficulty.
Breathing difficulty, yeah, breathing difficulty. A patient who is having respiratory distress, desaturation, obvious red flags, right? What is your primary treatment?
100% oxygen.
100% oxygen using?
NRBM.
NRBM, non-rebreathing mask, 100% oxygen. Actually, even though we just told it is respiratory distress or desaturation, any patient whom you are suspecting to have decompressive illness, decompressive sickness, you should start on 100% high flow oxygen, not 100%, high flow oxygen using non-rebreathing mask. That is a must. So that you will start, even though this patient is having most probably a bubbles in the trapped in the muscles, you need to start the patient on high flow oxygen on NRBM. Okay, what else?
IV fluids, rehydrate.
Okay, so you need an X-ray. Because you need to make sure there is no pneumothorax and pneumomediastinum. So you need to take an X-ray from ER to rule these things out. Because if this is there, patient goes into type 2 category, much more serious in nature. So you need to take this, and mostly this is not only to rule out pneumomediastinum and severity of illness. What treatment did you give to this patient?
Oxygen.
Hyperbaric oxygen,
Before
right?
that, to rule out
Pneumothorax is a
with
direct
worse
contraindication for initiating hyperbaric oxygen therapy because you are increasing pressure. Where will all this air in the pneumothorax go? Into your body again, isn't it? So if you're going to put the patient on hyperbaric oxygen therapy, you need to drain pneumothorax. Okay, so pneumomediastinum and pneumothorax has to be ruled out. So X-ray is a must. What else? Circulation. Diving causes air, as I told, bubbling of air will cause inflammation, endothelial activation. There
Loss
can be
of
third
third
space
space
loss
fluid
of
loss.
water.
Oh,
So
that's
patient
right.
will have
Dehydration.
dehydration. So rehydrate the
Rehydration.
patient. What else?
Other painkillers.
Will you give
Anesthesia.
painkillers? You don't have to give painkiller because the symptoms are due to excess gases. Once you give 100% means high flow oxygen, symptoms should subside and pain should be taken care. Most of the textbooks tells not to give analgesics, especially NSAID. The NSAID should be avoided is what is written. That's one thing. What else? Asking the patient whether they are having any chest pain. Chest pain can be due to pneumothorax, but can be due to coronary events. This is a stressful condition. Patient can develop coronary event, can also develop air embolism into the coronary artery. So need to rule that thing out. What else? Neurological deficit. That is your disability. Check for paresthesia, check for extremity movements, any neurological deficits. These are the red flags you look into a patient coming to here, right? Anything else? Yeah. So if you take like this patient is having breathing difficulty or pneumothorax, you took a X-ray, you are getting pneumothorax, or you are palpating and you are getting subcutaneous emphysema. So you know that there's a escaped air in the lung cavity or mediastinum, and patient is having one-sided weakness. What will you do?
Drain the pneumothorax first, then.
Yeah, true. Obviously, we will put ICD and drain the pneumothorax. But how are you going to prove it's air embolism? What are you going to do investigation-wise?
CPK.
CPK is muscle injury, right? Patient, you are saying you have a pneumothorax, you have one-sided weakness to the patient. What are you going to do? Yeah, you take a MRI. You take an acute MRI of the brain to look for CV event to see whether there is a ischemia or not. If at all you can do that, you can't do that. You can at least take a CT. Why you want?
To rule out bleed.
No, yeah, to rule out bleed, obviously, because it can be trauma induced also, but you can see air. This is air embolism we are talking. So in CT, inside parenchyma, you can see air, which should not be there. So that's the easiest way you can say, air embolism induced ischemic event. Similarly, you can take a CT thorax with contrast, iotogram or arterial contrast, which will show air bubbles in the right atrium. So if patient is having like air embolism features, right atria will be the one, because venous, the bubbles comes through the venous section, right? Then it goes out to arterial. So you take a CT thorax with the contrast, you will see bubbles inside right atrium, right ventricle, all these areas. So you know that, okay, there is bubbles present. But do you do all these things? No. Decompression, illness and air embolism, AG, air
Arterial gas
embolism is a clinical diagnosis. So the moment you diagnose it and you have presumptive features of it, you go for HBOT. Okay. Anything else?